We're going to switch over to talk about the criminal code laws concerning HIV, including the provisions related to biting, spitting, donating organs, and donating blood. All right. And we will start with Dr. Bree Weaver.
Hi. I believe we have slides, and I'm guessing this is my advancer. Okay. Okay, great. Thank you all for being here today and for allowing me to speak. As mentioned, my name is Bree Weaver. I'm an HIV expert and faculty at the IU School of Medicine. I'm also the Chief of Internal Medicine at Eskenazi Health, and I provide HIV care to individuals at both Eskenazi and Riley Children's Hospital. I'm the medical director of the Midwest AIDS Training and Education Center. And I say all of those things just to let you know who I am, but I'm not here on behalf of my employers today. I'm here on behalf of my patients. I'm deeply concerned that Indiana's HIV criminal laws don't reflect current scientific knowledge about this condition. And this concern is especially pronounced and hits home for me because they undermine my ability to bring people into care and to keep them in care. And I want to be put out of a job. I want to put the HIV epidemic behind us. So hopefully today I can provide you some information about the key scientific developments that have come to light since these laws were originally written. So at the beginning of the AIDS epidemic, the disease meant suffering and dying, typically within months of diagnosis. And when little was known about this virus and its transmission, people were panicked. There was tremendous fear surrounding this new, invariably fatal disease, and the medical epidemic and the epidemic of stigma grew together. Individuals that you might recognize experienced discrimination, and this not only came from others, but it was also internalized. They felt like they were dangerous to other people. And this was all while they were fighting for their lives. I'm not advancing. There we go. But over time, the causative virus was identified and named. The routes of transmission were better delineated, and medications to treat HIV were developed. And then in the decades that followed, treatment became much more effective, much more easily tolerated, and was eventually available for many people as one pill once a day. Other advances that occurred are pre-exposure prophylaxis, or PrEP, which is medication that someone who does not have HIV can take to prevent acquiring HIV. And we even now have long-acting injectable HIV prevention and treatment. So we know the ways that HIV can be transmitted, and we know the ways that it cannot be transmitted. And we now understand the impact when someone is taking preventative measures and when someone is not taking preventative measures. So HIV can be transmitted by transfusion and plasma-derived treatment, mother-to-child transmission, and penetrative sexual contact. But on the right-hand side of this slide, you'll see the ways that HIV cannot be transmitted. So it's important to understand that HIV is actually harder to transmit than most people realize, even when people aren't taking preventative measures. So early in the epidemic, when these laws were written, these statistics on the slide were not known. So this table shows the per-act chance of HIV transmission to an individual, from an individual with HIV to another when preventative measures are not being used. So the chances of transmitting HIV from the most risky sex act is less than 2%. So while this number is not nearly as high as a lot of people believe, a lot of people think the risk is over 90%. There is a way to get this already low risk to zero. And we've been using this tool since 1996. We just didn't know the preventative effect it was having at the time. So as I mentioned, treatment advances, not slide advances, there we go. Treatment advances have completely transformed HIV from a fatal disease to a manageable chronic condition that has minimal impact on a person's health or longevity. Since 1996, which was after nearly all of Indiana's laws were enacted, life expectancy has rapidly approached that of individuals without HIV. So in other words, the impact of HIV itself on someone's lifespan, if they're taking their medications, is now negligible. But the biggest, most exciting breakthrough was the realization in 2011 that those with a suppressed viral load as a result of treatment could not transmit HIV to others. So our treatments keep people alive and well, but it's also the most effective way to prevent HIV transmission to others. With consistent treatment, the already low risk of sexual transmission becomes zero, because people who consistently take their HIV medicines reach a viral load in their blood that we call undetectable. This has been popularized as undetectable equals untransmittable, or simply U equals U. Public health and medical professionals refer to it as treatment as prevention, or TASP. So the paradigm-shifting studies that are noted at the center of this slide all reported the same finding. Everyone with HIV who was engaged in care, successfully treated, and had a viral load of less than 200 copies per milliliter did not transmit HIV to their sexual partners. So based on these studies, public health officials have definitively declared that people living with HIV with an undetectable viral load are not capable of transmitting the virus to others through sex. So there have been a number of other medical advances in the past 2 decades. We have numerous ways to prevent HIV transmission. We virtually eliminated mother-to-child transmission in the US, and people living with HIV can conceive babies without transmitting HIV to their partners, like the gentleman at the top with multiple babies. They can safely use reproductive medicine without transmitting HIV, and they can be organ donors to other people living with HIV. This slide shows the care continuum, which is a model that we use to score how well we're doing with engaging people in care and partnering with them to achieve an undetectable viral load. So we want the score on each of these red bars to be above 90. But Indiana data show that the number of people living with HIV who are not in care and who are not accessing medicines or taking medicines are much below that. So they're not reaping the benefits of an undetectable viral load, including zero risk of transmission. Many studies and years of collective experience caring for patients living with HIV suggest that the main risk of lack of engagement is HIV-related stigma. This stigma creates fear of being identified as a person living with HIV. It creates mental health issues and isolation, keeping many people from even getting tested and also from engaging in care or taking their HIV medicines regularly. The outdated laws add to stigma. So current law undermines our trust as physicians with our patients because I have to inform them of these laws. So the moment I have a person sitting in front of me learning their HIV status, it's already a difficult experience for them. I'm required to inform them that the law views them as potentially criminal. And as the messenger, my relationship with my patients immediately takes a hit, and their trust in me declines. And it compromises the assurances that I bring to them that they can lead normal lives with treatment free from stigma, which risks me losing patients from my care. And the more patients that don't return, the harder it becomes to defeat HIV. So one of my specialties is pediatric HIV care. I mostly take care of kids born outside of the US, and I love to help each of them live a healthy, happy childhood. It's been one of the most meaningful and rewarding experiences in my career. I just left pediatric clinic this morning, double high five to 6-year-old because he's taking his medicines and he's incredibly healthy. But when he becomes 11 or 12 and I share his HIV status with him, I'm going to be forced to stigmatize him by informing him of these outdated laws. And he's going to be dealing with adolescence, transition to adulthood, becoming tired of taking pills, and I don't want to bring that to his life. I want him to be a happy, healthy kid. So I think it's imperative to reduce barriers to engagement in care and consistent treatment, to reach all of our shared goals, to maximize the health and well-being of people living with HIV, and to prevent new HIV transmissions. Reducing HIV stigma is key to achieving these goals. In conclusion, the laws being reviewed today were written decades ago, during a time of limited medical understanding and tremendous fear of HIV and the people living with it. Since then, scientific developments have substantially changed the realities of living with HIV and the risks of transmitting it. When taken regularly, today's often daily medications restore the immune system, increase the length of life, and eliminate the possibility of transmission. So this new reality requires modernization of Indiana's HIV criminal laws to reflect the contemporary scientific understanding of HIV, to eliminate criminal sanctions based on HIV status, reducing HIV-related stigma, and accelerating the end of the HIV epidemic. So you also have a letter from my colleague, Dr. Alexander, which was written on behalf of the Indiana State Medical Association. The ISMA has been supportive of recent legislative efforts to modernize the HIV criminal code. Thank you, and I'm happy to answer any questions.
Senator Poole.
Thank you for being here today. In one of the earlier slides, you had covered the transmission rate with the various acts and situations. Are those numbers that have always been known, or are those modern? That's just essentially modern data that demonstrates that, and that was without condoms or without any type of treatment. So has that always been the transmission rate, or is that a development that has come, with the, I guess, what's the word I'm looking for? With the evolution of the condition or the disease?
Mm-hmm. Thank you for that question. So no, those numbers were not always known. It took years and years of following individuals living with HIV and conducting large studies of individuals living with HIV and partners not living with HIV to be able to ascertain those actual numbers. So no, people didn't know that a long time ago. I believe the study from which these numbers came was published in 2014. So I can confirm that, but no, we didn't always know this. And it's important, I think, to keep in mind that these are without using any sort of preventative methods. So any type of prevention, and we have a whole toolkit of prevention, will help to reduce that.
Okay, thank you.
Yeah, you're welcome.
Senator Thomas.
Thank you, Madam Chair. Dr. Weaver, are you saying that if a person that has HIV bites someone and draws blood, that they can't transmit the HIV? Is that, and they're not taking medicine or anything, that it's not transferred that way? It's not transmitted?
So biting is not a well-established route of transmission. And in cases documented in the very remote past, there was substantial trauma that was related to it. I can get more information for you on that.
Okay, but I'm just asking, absolutely cannot be transmitted if somebody with HIV bites someone and draws blood from that bite. It can't be transmitted? Is that true?
There's a theoretical risk, but infinitesimally small, and it would have to also be accompanied by trauma in both cases. So trauma to the mouth of the individual biting and trauma to the person.
So it's not absolute, then it could be transmitted to the bite?
I think it's a theoretical.
Thank you.
Mm-hmm.
Senator Taylor.
Thank you, Madam Chairwoman. Kind of follow up on that question related to biting someone. Under our criminal code, there's already correct me if I'm wrong, I know you're not a criminal attorney, but I believe there's already a statute that says if you bite someone that can be seen as battery or cause substantial harm to someone's body, right?
I appreciate that question, and I will have to agree with you that I can't answer that question. I'll defer to some of the speakers who are going to speak after me.
Oh, okay, good. I might be able to. They might be able to elaborate because I remember the discussion of this matter. I don't think it was. I wasn't here in the '90s, but I remember HIV. Having if you spit on someone and you have HIV, that could be battery. I think is the charge.
Again, I can't answer the question about the laws. I can tell you that saliva can't transmit HIV.
Okay, I just got the folder. But what does it say?
It lists the charges.
In this folder here? All right, so what this, okay, guess, all right, thank you.
Okay, any other questions? All right, thank you very much. Dr. Carrie Foote.
No, you all must be getting hungry. It's lunchtime. So keep you on your toes and alert. So thank you, Madam Chair, members of the committee. Get my bearings here, my clicker. So I'm really excited to be here today. I'm a sociology professor at IUPUI and an expert on HIV stigma and HIV criminal laws. I'm also one of about 13,000 Hoosiers living with HIV across the state of Indiana, and I chair the HIV Modernizing movement, which is a statewide coalition of healthcare providers, public health leaders, people living with HIV, and others who are working to modernize Indiana's HIV criminal laws. I am here on behalf of the coalition today, and I am joined by some of my peers living with HIV. You'll recognize us. We're wearing the red T-shirts in the room. Really excited here because some of them drove as far as Scott County, Indiana, in southern Indiana to be here with us today, and from LaPorte County in northern Indiana. This topic is very important to us. As people living with HIV, we know firsthand how these criminal laws increase stigma and cause harm. The past few years, our group has worked very closely with legislators to update the Indiana Code with more person-centered language to improve how we talk about a person living with HIV. Now it's time to examine the criminal code, the research on the topic, and discuss how we can potentially modernize these laws. So you have folders in front of you that had copies of Dr. Weaver's presentation, has copies of my presentation, so you have that with you, as well as our brochure. There's a lot of information in there. I'm a professor, so I try to give everybody all sorts of information, but I'm just going to touch on a few different highlights throughout my presentation, take maybe about 12 minutes or so to for sure allow enough time so that you can ask on anything in the presentation that you'd like me to elaborate on. So just kind of going back to the early years when these laws were first enacted in Indiana. This slide illustrates the context of HIV when Indiana's HIV criminal laws were first enacted. So the earliest law of all the laws that we're examining here today was the blood donation law, and it was enacted in 1988, which happened to be the same year that I tested positive for HIV. At that time, when I learned my status, I and everyone diagnosed then was told we would die within a few years. Fear and hysteria were extremely rampant. Unlike today, the blood supply was not safeguarded. And the disease was very poorly understood, not just by the general public, but even researchers and medical professionals didn't understand the new disease. Fortunately, I lived long enough to benefit from modern HIV medicine. I've been living with HIV for 34 years, a really, really long time. I'm very, very grateful to be here and to benefit from that. And fast forward to today, what does the landscape kind of look like for people living with HIV? So this next slide showcases that, some people from across the state of Indiana who are living openly with HIV in our state. And it shows that people can live extremely well, as we just learned from the previous presentation. Yet despite people living extremely well, thriving, doing what everybody else does in life, working, having families, and that sort of thing, basically despite this, we continue to face stigma in many areas of our life and possible criminalization under Indiana law due to our HIV status, even for acts that pose zero risk of HIV transmission. As just one example, under Indiana law, with our battery by bodily fluid that has sentence enhancement, if you're living with HIV, if any of you spit on me in Indiana, that's a crime. Not a very nice thing to do, right? But it's a minor crime if you spit on me, a misdemeanor crime. But if I spit on you, it's a felony crime. I face a very serious crime. I face sentence enhancement for my disease status, even though spit doesn't transmit HIV. So we are punished more harshly because of our disease status under Indiana law. So these next two slides that I'll just go through very quickly kind of shows some of the things that happen in Indiana under our laws over the years. So as these arrest examples show, many people are being charged for acts that pose no risk of HIV transmission and no actual physical harm and are facing 2.5 to 6 years in prison. Other outcomes include some people did not return for their HIV test results when they learned about Indiana's HIV criminal laws. A woman faced physical harm from an abusive male partner when she was asked to disclose her status when she first learned her HIV status under Indiana law. A doctor threatened to have a newly diagnosed patient arrested. After a contentious breakup, a man threatened his ex-girlfriend that he would falsely accuse her to make her pay for leaving him. So what are the laws that we're looking at today? This table outlines the 6 Indiana codes that we're looking at as being outdated and in need of modernization. As you can see, they're a mixture of criminal and public health code provisions that were enacted decades ago. Again, the oldest one is 1988, going up to 2002. Almost all of these were enacted before effective HIV treatments and the science of U equals U, as well as before we had effective procedures with the FDA that protects the blood supply from all bloodborne diseases, not just HIV, but things like viral hepatitis in the blood supply. So a few things, I guess I think I'll just highlight a couple things on our laws to point out some of the concerns that we have with Indiana laws. Some also apply to people living with viral hepatitis and tuberculosis, as you can see, but people living with HIV are targeted under all of these laws. Under one, they are punished more severely than people living with viral hepatitis and TB. The old language of warn in the disclosure law, which we've modernized to now be inform, kind of illustrates the fear behind the enactment of these laws. We were essentially required to come with a warning label. They also have inconsistent punishments across the codes. As just one example in the inconsistent punishments in the first row, a section in the health code is a felony 4, but the identical prohibition in the criminal code is a felony 3. And then we also see that nearly all punished behaviors that cannot transmit HIV, such as placing bodily fluids where someone will touch it or attempting to donate blood products. Intent to transmit is not part of any of these laws. This means that people who have no intent to harm anyone and did not in fact place anyone at risk of transmission can be convicted. This results in disproportionate punishments. So the next slide reports on the very first study to be done in the state of Indiana. It's a research project that I'm working with colleagues at the UCLA Law Institute to examine the application of Indiana's laws. How are they applied? Who's arrested? What's happening in the context of these arrests? So what we see here is that a total of, I looked at since 2015, because that was right after Indiana reviewed and did some revisions to the entire Indiana criminal code. And we found that between 2015 and 2021, a total of 164 people had any court contact based on their disease status, which is approximately 1 person every 2 weeks. The vast majority of these laws are not used, or they're rarely used. The disclosure law has only been applied to people living with HIV, never to people living with hepatitis B. Of the known cases involving viral hepatitis, nearly all are for hepatitis C, which we now can cure hepatitis C, a very kind of simple regimen that people take to cure the disease. A few for hepatitis B, and we've had no court contacts with anyone living with hepatitis A or tuberculosis during this time. And we have found at least 1 person in this data set who was arrested who was cured of hepatitis C, yet they were still charged with the sentence enhancement for having hepatitis C under the battery codes. Next 2 slides show additional findings that we're looking at analyzing news reports for cases that make the news and are written about, and then probable causes for arrest documents, because we were very interested. Well, what's happening? Why are people being arrested? Of the few donation cases, they're very rare when they happen. The ones that we've been able to identify are all plasma centers. Of the battery cases, the vast majority are for spit. Less common are for blood smearing on another individual, biting, and throwing urine or feces. Essentially, none of these acts are established routes for transmitting HIV. And as this quote on the right shows, at least one person was even charged for coughing due to her HIV status. The laws are also being used in contexts for which they were not designed. They disproportionately affect poor people, therefore requiring a public defender, creating unnecessary financial costs to the state. They also result in sensational news reporting, and because our health status is part of the criminal code, it's suddenly made public even before we're tried, found innocent, guilty, charges dropped, which sometimes happens. The charges are dropped in these cases, but now our health status is a matter of public record in the public eye, when normally that's usually protected, our private health information. The next two slides just summarizes some of the problems with these laws. All the research that has been done has shown they don't work as intended. Not a single study has found they increase disclosure or reduce HIV transmission. They do work against public health by doing all the things listed here on the slide. As just one example, there is a slogan we often hear, take the test and risk arrest. And the reason, the rationale behind this slogan is that knowledge of one's HIV status is a key element of the crime, that you can only be prosecuted if you know your HIV status. So it actually creates a disincentive to testing and learning your status, which we want people to know their status. This is a good thing. It's good for public health for people to know it, and we don't want anything to create a barrier to HIV testing, but these laws can do that. They also don't align with current HIV science, as the previous presentation showed us. Now, these next two slides provide examples of the actual text of what we're looking at when we're saying, well, how do you amend these codes? How do we modernize them? What exactly is problematic about the codes? What are we looking at here? So the two slides that you'll see, the two codes are the contaminated body fluids, which is attempting to donate blood products, and then the battery by bodily fluid with HIV, hepatitis, sentence enhancement. So the problems with both of them are exactly the same with both of these codes. If you look at them and you read them carefully, you will see that no intent to harm is required at all in either of these. Often in the criminal code with a crime against another person, the intent matters, right? Mens rea, is there a guilty mind of somebody actually trying to transmit HIV? That's not a requirement of these statutes. No harm is actually possible under these, the way that they're written right now. That's just not how HIV is transmitted. And then by spreading misinformation about HIV, for example, vast majority of the cases under this particular code are for spitting, it sends the message to the general public, to people working in the courts, that spit can transmit HIV, so it creates unnecessary fear. You know, we want people to be safe, we want people in law enforcement to be safe, correctional officers to be safe, who might be involved in some of these battery by bodily fluid cases. And fortunately, this is one situation they don't have to worry about HIV, because that's just not how it's transmitted. But there's fear because we have laws that punish that, so it sends the message that you can transmit HIV. And both have disproportionate punishments. So I think I was on the other side of the room, so I'm not sure who asked the question about battery, that we do have laws, battery by bodily fluid, that can result in bodily harm. And the levels are basically bodily harm, moderate bodily harm, and severe bodily harm. So a level 5 felony is equivalent to serious bodily harm, the highest level of harm. A level 6 is moderate bodily harm, which is pretty serious as well, moderate. Yet neither of these HIV codes that I just showed you require any bodily harm for the crimes of the equivalent of being punished with either a level 6 or a level 5. So there's disproportionate punishments also going on in these codes that we recommend we look at and try to evaluate, you know, what might be a more modernized version of the Indiana code. So kind of moving on, HIV criminal laws and stigma make it harder to end the HIV epidemic. We also see that the burden of HIV falls disproportionately on Black people, sexual minorities, and people who inject drugs. Researchers report that HIV criminal laws also disproportionately impact these groups, thus exacerbating HIV health inequities, making it more difficult to end the HIV epidemic. And I do know that my colleague, Tony Gillespie, was scheduled to testify today on behalf of the Indiana Minority Health Coalition, but had a last-minute conflict. The IMHC has been very supportive of HIV law modernization, precisely because they can worsen these existing minority health disparities that we're trying to eliminate in the state of Indiana. So looking across the U.S., this is not an isolated effort that we're trying to do here in Indiana. There is a movement to modernize outdated laws that exist. There's a hodgepodge of laws across the U.S. as this map shows here. There are several medical, legal, and public health experts all across on a national level, also including here in the state of Indiana, who are advocating and working actively to reform laws such as the Center for Disease Control, the American Medical Association, the National Institute of Defense Lawyers, and the White House Office of National AIDS Policy. What you see in this map is what's interesting is all the gray states, they never had any laws. And there's no consistency in which states. You can see they're all over the country in all different parts of the state. So 17 never had any HIV-specific laws. The red states, there's 20 of them, have not modernized or repealed any of their laws. Of those, 12, including Indiana, have active modernization efforts going on. The gold states are states where 13 states have modernized or repealed. Among those, 11 have modernized, and I'll explain what that means in a minute. 2 have fully repealed. And again, those are all over the United States. You can see that there's really no consistency, and are there commonalities in these states and what states are doing? Basically, the main commonality is that the laws are outdated and in need of reform. We've come leaps and bounds in the last several decades when it comes to HIV. So best practices, what are they? There's been some research. What would be best practices for modernizing and reforming the law? Number one, best practices would be to reflect the current science of HIV transmission, treatment, and HIV as a chronic manageable condition. And then 2, if there is going to be an HIV or disease-specific law, to narrow them to situations involving an intent to transmit and a significant risk of transmission. So the different options that we can look at are you could fully repeal, remove the laws, remove the sentence enhancement based on disease status, or you can modernize the law so that it's basically just limited to those cases that require an intent to transmit HIV or another serious disease, as well as a significant risk to transmit, and then proportional punishments. You could also just decrease penalties, or you can do a combination, and by decreased penalties, go from a felony to a misdemeanor charge. And you can do combinations of those. So HMM, you know, in our work that we've been working on this, for Indiana, we could recommend a mixture of repeal and replace. And this is all the different codes. There's 6 of them, 4 in criminal code and 2 in public health code that are kind of linked to the criminal codes. To completely repeal the donation codes, the FDA keeps the blood supply safe. I believe you have a letter from the Indiana Red Cross that kind of documents, you know, how they keep the blood supply safe for Hoosiers across the state of Indiana. They don't rely on the HIV criminal laws to do that. To modernize the HIV non-disclosure law to become an intentional disease transmission law, to remove the sentence enhancement related to health status for the other 2 codes. And for that, I want to emphasize that the base crime stays the same. We wouldn't touch anything with the base crime of battery by bodily fluid. So anyone, myself, if I aggressively spit on another person, that's still a crime. If it's a civilian, it's a misdemeanor. If it's a public, health officer, safety officer, it would be a felony, just like it is for any citizen in the state of Indiana. But I would be treated the same, and my, other peers living with these diseases would be treated the same under the law. So the base crime stays the same. These changes would ensure the laws are fairly applied to people living with HIV, and at the same time protect the public health by ensuring anyone who intends to transmit HIV and then engages in an actual behavior that can do that is held responsible under the law. So in closing, Indiana's HIV criminal laws were enacted decades ago and are in need of modernization. If the HIV epidemic started today, like right now, and was a chronic manageable condition with multiple methods of prevention available, like we have today, we would not be enacting these laws. And we know this because we are protecting the public's health without the use of the criminal laws for recent serious communicable disease challenges in our state, such as syphilis, COVID-19, and now monkeypox. The criminal law is not being used to contain those epidemics and have an effective public health response. These laws are scientifically outdated by having no public health benefit and by increasing stigma and hindering public health efforts. These laws have the perverse effect of making it harder to end the HIV epidemic. So I really think together we can change the law, we can end this stigma, we can change the slogan from take the test to take risk arrest and take the test and risk arrest to take the test to live your best. We've got some good slogans with HMM, things that make you go, So, and achieve our shared goals of removing barriers to testing and care, and ending the HIV epidemic in our state for the sake of people living with HIV and for the health of all Hoosiers. So on behalf of HMM and all my peers who were able to join me today, I just really want to thank you for holding this study session. It's such an important topic, and I'm happy to answer any questions anybody might have.
Representative Pierce.
Thank you, Madam Chair. Do you have any research that compares the transmissibility of HIV and TB and hepatitis, the other things in the statute? Are there any difference in the likelihood you will contract the disease?
So HIV is the least likely to be transmitted. So it's very interesting because of all the diseases, HIV is singled out under all the laws to be potentially punished for certain behaviors, whereas some of the other diseases are only under some of the laws. And again, this kind of ties into the stigma and misunderstanding of how exactly HIV is transmitted. And if we go back to my colleague Dr. Weaver's slides with the chart that had, how is it transmitted? What is the likelihood? It's not an easy virus to transmit. As soon as it hits the air, it dies. And that's why we don't see huge numbers of people living with the disease the way we do hepatitis C or hepatitis B. So I don't know the exact figures there. My colleague, Mr. Turner from the Department of Health, may know a little bit better about the differences. But out of all of them, HIV is the least likely to be transmitted, yet it's the one that people think is the most likely to be transmitted. And that's just carrier kind of over from the early years of when the epidemic came out, and just stigma and misunderstanding that, unfortunately, like, we have these great treatments, but we're still battling this stubborn epidemic of stigma that we're trying to overcome in our state, and just educate that, here's how it's transmitted, how it's not, very delicate virus that, even a lot of times folks think one sex act and you're going to automatically transmit if you're not on treatment. And that's just simply not the case, as that chart showed. So. And TB is airborne, which is also interesting too there, because with an airborne disease like COVID, we're not criminalizing COVID, which is also airborne, and that sort of thing. And how would you even determine, like, if a cough, was that intentional, not intentional? Like the individual who was arrested for coughing while living with HIV. And it was posed in the probable cause for arrest that this posed a serious health risk. It was in the context of law enforcement. There was no health risk. Law enforcement didn't know that, because they don't, from the top, get the best bloodborne pathogen training on the job. It's very basic, very simple. So,
Bernice.
That was actually my question, but I have a follow-up based on your answer. So given that my recollection on TB and hepatitis, while obviously there is a cure for Hep C, which is extremely expensive, and if you don't have health insurance, you don't really have access. So just thinking about someone who has hepatitis B or C, and thinking about TB, which is highly transmissible, as you said, is the difference in your mind, because in my mind, I don't equate those conditions with HIV, given what you just shared. I think TB and hepatitis can be more transmissible, obviously, so I agree with you. Is your point in terms of including those other two conditions along with HIV in terms of updating the statute, is your point that a mens rea would take care of any concerns about transmission, that basically we can treat all three conditions the same, because if you add the mens rea, or that kind of takes care of it, or just repealing them all together, the public is still safe, even though TB is, highly transmissible as well?
Yeah, so interestingly, in this data set, we only looked at 2015 to 2021 because theoretically it made the most sense for what we're trying to do in terms of modernizing the law. There was not one case of anyone being charged with TB in that time frame. But if you just kind of step back and you just don't even think about the diseases and you look at the language of the law, it's precisely the problem is it's missing what is classic in a law that would be a harm to another human being, which is that, did you intend to do harm? Was harm even possible? And then if harm occurs, what should the punishment be for that? And you should have proportional punishments, which of course can vary depending on, cultures of punishment, which varies by different states and that sort of thing. So the whole idea is that it's missing that. So a lot of these, particularly with the battery by bodily fluid, as you could see, was the most used law with the sentence enhancement for HIV and hepatitis. We're reading probable causes for arrest, and what we're finding in those, that the individuals, in almost all the cases, it's a state of distress. Almost like a mental health crisis is going on, a situation where someone's being arrested for other crimes, and then it's learned in the process that they're living with HIV or hepatitis. They might bleed, they might spit, they might even, say something like, I have HIV, to a police officer, I hope you get it, which is a threat to a police officer. No one should be threatening a police officer. But HIV is not transmitted they're in a state of distress. What should the crime be? What's going on? Our laws, the way they're worded, don't really address that. It's based on, are you positive or not? And that's the only difference in that particular code. So if we were to modernize them and based it on intent, it would resolve all that and solve just the whole issue. In a way, it doesn't matter. And we don't really want to see more diseases criminalized. Like, we won't want to say, well, let's criminalize COVID-19. We don't want to see a disease. Any crime should be based on intent to harm, was harm possible, significant risk of harm, and then do it that way and punish someone. And right now they don't do that. So if there ever was an individual who actually intended to do that, the way our laws are written, they can't punish that particular crime. You'd have to go to the general criminal law, which also is not the best solution because it's not designed originally for a disease context. So that's kind of what we're looking at, is more like a repeal and replace of how do we modernize it, make it reflect best practice, modern science, and then best criminal justice practices, which would be based on intent to harm, significant risk, and proportional punishments based on that.
Senator Thompson.
Thank you, Madam Chair. Dr. Foote, thanks for your testimony, very informative. Interesting you would say something about COVID, because in the height of that, I had several emails came into me that people wanted anybody not wearing a mask be put in prison until the COVID was cured. So it's funny that you brought that up. But can this be transmitted through tattooing?
No.
Really?
No. And so there's been not one known case of anybody contracting HIV from a tattoo. And it's one of these things where, because HIV does live in blood, right? We know that. But it's only transmitted in very specific ways with blood. So penetrative sex, prior to the FDA kind of protection of the blood supply, people did get it through transfusions. People did get it through plasma-derived medications. Ryan White from our state, but that doesn't happen anymore because of FDA's protections of the blood supply. So now with tattoos, and it has to do with the type of tattoo and the needle that they're using in tattoos, it's not pulling up blood from somebody. It's, do you have a tattoo?
Okay, well, the reason I asked is
So it
because,
doesn't transmit that way in that particular case. So it's not a known route, again, of HIV transmission. That said, all tattoo parlors are required to have safety measures like universal precautions. It's not as enforced as medical professionals with universal precautions where you wear gloves, you take precautions with any kind of, you just assume everybody has a disease with universal precautions. And that's the way tattoo parlors tend to operate, is they just assume everyone who comes in there has a potential bloodborne disease, whether it's viral hepatitis, HIV, or something else, regardless of whether it's transmitted that way, and they just take precautions.
well, the reason I asked, I just read where CDC does report that it can be transmitted like that. Now, am I looking at something that's outdated because they're...
Yes. So basically, there's things like theoretical risk. I couldn't see over here, but somebody had asked a question about biting. So it's one of these things where theoretically there could be a potential risk of transmission in extremely unusual situations. Has it ever happened? No. So with biting, they do have, since the beginning of the epidemic, a few documented cases across the epidemic since 1981 of people contracting from biting with severe trauma, person at a very high detectable viral load, trauma on both sides, in the mouth, on the butt, but a very rare, unusual circumstance. There has not been one known case of anybody contracting from tattooing.
Okay, well, that was, I asked that because it's become a popular practice of getting tattoos now, and the CDC reports that you can get that way. That's why I was asking the question, but you said.
And there is, the precautions would be taken, in the tattoo parlors, but no, it's not something that you would have to worry about if you go in and get a tattoo.
I see, okay, thank you. Thank you.
You're welcome. Thank you for the question.
Okay. Senator Taylor.
Thank you, Madam Chairwoman. I was the one that asked the question about the bite and the level. This would be an enhancement of the battery, correct? Knowing or should have known that you had HIV?
Yes, so the way it works is the example, and I just use the example of spit because in our research data, the vast majority of folks are being arrested for spit. So if you spit on me right now, that's a crime, and you can face a misdemeanor charge in Indiana. That's the base crime. If I spit on you, there's sentence enhancement to a felony for me.
Gotcha.
Only because of my HIV status. So it has nothing to do with, did I intend to transmit HIV to you when I spitted, whether or not that was even possible? Was it, just we're in a heated verbal argument and you spit on me, I spit back on you? Was it even an intentional spit? In some of these cases for arrest, we're finding that there's not even an intentional, it's just spit happens. I mean, a lot of things happen when people are arrested and they're in distress. People don't like to be arrested. They get upset, they get angry sometimes. But yeah, so sentence enhancement.
Okay, so then that leads to my second question. One of the most disturbing things in your testimony to me was the disproportionality. I've always argued that if we just address the disproportionate enforcement of these laws for underrepresented people, we might find an underlying solution. So are you saying that in the sentencing or is it in the charging disproportionality?
In the actual law, so if you look at the actual law in your packets there, the wording of the law, essentially a person who knowingly, in a rude, insolent, or angry manner, places any bodily fluid or waste on another individual, commits battery, by bodily fluid, which is a Class B misdemeanor, the
right.
lowest level misdemeanor. The offense described there becomes a level 6 if the person knew that the bodily fluid placed on another person was infected with hepatitis, tuberculosis, or HIV. So the only difference is the disease status.
Okay,
There's
but-
nothing else different about that particular crime. So it's you're experiencing the enhancement. So if you didn't have the disease, or if you didn't, maybe you had it but you didn't know, or if somebody tells you, well, you should get tested for HIV, and they say, but by the way, one consequence, because we are told this in the testing situation, one consequence of being tested positive is that we do have these criminal laws in the state of Indiana, and you should know about them. Somebody might say, well, you know what? I don't want to be tested, because why would I want to experience that sentence enhancement?
I think, thank you for that. No, the question for you was, in your research, did you find that the charging was disproportionate, or was the sentencing disproportionate?
So right now, we've just gotten to the point of the first, when they file a court date.
Gotcha.
And we have the data from, okay, now what happens next? Because
Right.
the charges could get dropped. They could get, by the time it gets to the punishment stage, they could say, you know what, we understand spit doesn't transmit HIV, don't charge them with, for example, if it's a police officer, it's a level 6 for a civilian without HIV, it's a level 5 for somebody with HIV. They could just say, you know, just charge them with the level 6. So then they're getting rid of the sentence enhancement for HIV in there. So we're not that far yet with the data.
Okay.
We're hoping by the time we get to next session, I'll have a revised data set and findings for everybody so you can look at exactly what you're asking there.
Yeah, the reason why I asked that question is because charging comes from the prosecutor. Arrest comes from the law enforcement officer. So I'd love for you to get research whether or not, first of all, who's getting arrested for it. I don't know if that's in your
Yes.
data study. And then the charging, and then the sentence enhancement enforcement for the increased penalty. Because that actually, it doesn't, but it kind of shocked me when you said that. So I'd love to get that data
Yeah.
before January.
And that's great, and we're definitely working on
Okay.
that, you know, just, right, but right now, so that's why this is preliminary. It's kind of that initial filing of the court case. So it's past the stage of the probable cause for arrest, to where they said we have enough to file a court case so that someone will show up in court to address this. So that's what we're reporting here. Come January, we should have more data, exactly what you're asking for, and I'll be sure to tell my colleagues at UCLA to include those findings
Thank
so
you.
that we definitely have those in the data set.
I'm sorry.
Can-
Madam Chair.
We've got to move on a little bit, so if it's something that can be answered with brevity, which is one of my favorite words, please do so. You got one more question? Then, okay. Go ahead.
Thank you very much for being here today. Just one real quick question. How are prosecutors proving that somebody knowingly has a HIV positive status? I mean, to me, obviously, that's private health information. So how are they discovering that information to begin with?
So what we're seeing, and this is just from our beginning to look at probable causes for arrest and what happens there, is that often the person will disclose at the time of arrest that I'm HIV positive, I need my treatment. And so that they get continuation of treatment in jail. And then, so when you go in there, so they're actually sharing that information voluntarily. In all the cases that we've looked at so far, it's not a situation where the courts are saying, we think this person's HIV positive, test them. It's the person along the course of being arrested has acknowledged they're HIV positive. Because, treatment keeps us alive and well. It's a wonderful thing. And so we want to continue that. And most of the time, again, folks aren't thinking like, oh, if I share that, now I'm going to have another charge maybe added on to me. Because that's another thing we're looking at. Are these isolated events and the only charge, or are they in conjunction with other charges that they're being arrested for? But usually that's what we see happens.
Okay.
And I'm thinking brevity. Professors aren't very good at that.
No comment.
Thank you.
Okay. All right, thank you very
All right.
much.
Thank you very much. Really appreciate this opportunity.
Jeremy Turner?
Good afternoon. It's a pleasure to be here. Thank you to the chair and the committee for having us today. I appreciate that we have somebody from Vanderburgh County here because that's where I'm from. And this week, 18 years ago, is when I started working in HIV services back home in Evansville. So if you told me then I'd be here representing the Division of HIV, STD, and Viral Hepatitis for Indiana Department of Health, I would not have believed it, but I'm pleased to be here today. We're just going to run through some things here for my presentation. I'm going to provide you with some data from IDOH and about some of the work that we're doing for people living with HIV. The first slide here, you can see overall newly diagnosed HIV cases in Indiana are increasing. You can see the impact of the Scott County HIV outbreak in 2015 linked to injection drug use and the decline in new cases diagnosed in 2020 due to the impact of the COVID-19 pandemic. AIDS cases continue to decline in Indiana, which is good news. Both of these indicate why testing and linkage to care is so important. Access to testing, medical care, and supportive services is critical to ensuring prompt treatment and prevention of new cases. Elimination of stigma is vitally important to people accessing testing and medical care. One of the big things that we do, the largest program that we fund out of the division is HIV services. People living with HIV have access to comprehensive medical and wraparound services through federal grant programs and HIV care providers across the state. There are two categories of HIV services: medical services and supportive services. Medical services relate to medically treating HIV. The AIDS Drug Assistance Program, otherwise known as ADAP, provides HIV medications to those without insurance, and medical case management focuses on retaining people living with HIV into medical care. Access to these services and testing is critical for timely treatment and prevention of HIV, since living with HIV without detectable virus in the bloodstream cannot transmit infection. Here's one of the tools that we use to gauge the success of our programs, and I'll go through and explain what each phase of this HIV care continuum means. So far, you'll see in the first line there that we have 338 new HIV diagnoses from January 1 of this year through July 31st. HIV prevalence is the total number of people living with HIV in Indiana. Currently, that number is 13,337 that are known, and we estimate that that represents about 87% of people living with HIV in our state. The next item is people linked to care. Linkage to care is measured by people living with HIV who are linked to HIV medical care within 30 days of diagnosis. You'll see this number is slightly lower, and that's because we haven't always measured linkage to care in the same way. And so as that definition has changed, we're looking at the total number of people who've been diagnosed since the beginning of the epidemic, since we've been tracking this data. And if a person's not linked to care within 30 days of diagnosis, even historically beyond when we were measuring this, they will not fit into this category. And I'm very happy to report that we are now linking about 90% of people newly diagnosed to care within 30 days of their diagnosis. People retained in care, those are people living with HIV who received HIV medical care within the last 365 days. When we talk about care in this instance, that means that we have received a report of them accessing HIV medical labs that measure their viral load and CD4 counts. Suppressed viral load, total number of people living with HIV who have an HIV viral load of less than 200. And then the percentage of people living with HIV who need to be re-engaged in medical care, which currently stands at 24%. We have a plan to eliminate HIV and hepatitis C in Indiana. It's called Zero as Possible Indiana, or ZIP-In. The ZIP-In plan was specifically designed to mirror the national strategies for ending HIV and hepatitis C. The main goal of the ZIP-In plan, as well as the national HIV and hepatitis plan, is to reduce new diagnoses by 90% by 2030. Lowering new diagnoses and increasing the number of folks who are aware of their status, as well as ensuring they achieve viral suppression, are paramount to ending the epidemics. ZIP coalitions represent a coordinated, community-based approach to identifying needs, building system of supports and services to address those needs, and collectively monitoring progress while working together to strengthen the system to meet the needs of all community members. They are responsible for leading regional efforts to end the HIV epidemic and eliminate hepatitis C, including the engagement of diverse partners, especially people living with HIV and Hep C, and using data-informed approaches to set priorities and act strategically. By centering voices on folks with lived experience and enlisting a diverse group of traditional and non-traditional partners, we create innovative strategies that engage communities on their own terms, bettering health outcomes across the state. ZIP-In has 4 goals and several cross-cutting strategies that impact goals. By using these strategies, we can lower or eliminate barriers to ending HIV and hepatitis C. The first pillar is diagnose. How do we reach vulnerable populations to diagnose people as quickly as possible? Then treat. What are best practices to link people to medical care? How can we make sure that people stay engaged in the medical system after they've been linked? Prevent. How do we use proven prevention methods to prevent and provide best services for folks living with HIV or Hep C or prior to their infection, and then respond. Is there an increase in disease transmission, and how can we be prepared to utilize our resources efficiently? Stigma is often brought up as the biggest barrier for receiving HIV services. The fear of being discriminated against based on HIV status keeps people from seeking treatment and care. By eliminating negative stigma, we can increase utilization of our services to diagnose people with HIV as early as possible, connect them with HIV medical services, and prevent new diagnoses by responding to outbreaks utilizing HIV services. We have many tools that we can use on our road to eliminate HIV. First of all, we know that many people, once they're diagnosed with HIV, that's the biggest step that they can take in preventing transmission of HIV to others. PrEP is also a new biomedical intervention we have. It's a preventative medication to stop transmission of HIV for folks who aren't living with HIV. Recent federal legislature has made it easier than ever for high-risk populations to access PrEP. HIV loss to care services are also a vital part of what we do. We re-engage people living with HIV who've not received HIV medical care in over a year. And then harm reduction also plays a role. Usage of methods to reduce the harm that may come from certain behaviors, using protection, using PrEP, etc. That's the last slide that I have. I'd be happy to answer any questions that you all might have about what we do at IDOH.
Okay, any questions? Representative Pierce?
Thank you. Just a couple quick ones. So of those 338 new cases, do you know how they were mostly transmitted? Was it a needle sharing pretty much among?
Most of the new cases in Indiana are transmitted by sexual contact. I can say anecdotally, I'd be happy to provide that because we do track that information. I don't have it in front of me, but it is interesting over my 18 years of work in the field to see a slight rise in injection substance use being a more common risk factor for people as we've dealt with the opioid epidemic. But sexual transmission remains the number one route of transmission in Indiana.
Okay, and how does the 338 new HIV cases compare to, say, how many new or how many new cases of TB or hepatitis or other diseases?
So we're a lot higher prevalent state for hepatitis. We don't track TB in our division, but that's something that we can work with our Epidemiology Resource Center to give you a report on.
So I'm just trying to figure out how to put that number into context, right? Because for the 338 people, that's obviously a pretty dramatic event in their lives. But maybe if you think you have 7 million people in the state,
Sure.
338 is a pretty small number. So, because I think what we're trying to figure out here is how prevalent. I mean, we've got data that's it's really hard to get.
Sure.
But 338 people got it, so we're trying to figure out how to put that into context.
Absolutely, and I'd be glad to provide some information on that. I can tell you that Indiana is considered to be a mid to low incidence HIV state. We're around some of our partners like Iowa when it comes to that. A couple of years ago, though, we were #1 for acute hepatitis C rates in the country. And so that is, quite a bit different story. I'm glad to report, though, that we've dropped off from that. And they haven't released the most recent rankings, but we are now probably around #8. And then we were ranked as one of the top 6 states in the country to be equipped to end the hepatitis C epidemic, which is great progress for us. But I can give you the numbers related to all the other infections, and I'll reach out to ERC for TB info.
Okay, yes.
Thank you, Madam Chair. As a quick follow-up to that question, can you also add how many women have fallen at 338? And I ask because really pleased that the state provides PrEP, and I don't know how many people get that information and make use of it, but as I understand it, PrEP is PrEP not for people born female, or is it for both?
So PrEP is for people with high-risk sexual behaviors, essentially, or high-risk behaviors. And so we would recommend that people who are, in certain kinds of risk situations be connected with PrEP services. And that's more of a conversation that we encourage folks to have with medical providers. But I can send information related to how PrEP services are accessed and referred. But, that would be dependent on what the activities of the person at risk might be.
But it can work for men and women?
Yeah.
Okay, thank you for that.
Senator Thompson.
Thank you, Madam Chair. Jeremy, did you say the HIV is increasing in Indiana? Was that a statement that you made?
We continue to find new cases every year. We've been fairly static with the number of cases that we found year over year for quite some time now. So far this year, it does appear that we're finding a few more people than we might expect, but you never know what the numbers are going to look like by the end of the year. One of the things that we do know is the COVID pandemic impacted our outreach efforts that we would normally do to at-risk populations, and so we had a big reduction in the number of tests that were being performed because folks were not coming into doctors' offices. More people were accessing services via telehealth and only coming in for emergent situations. So we do anticipate that we'll have to catch up a little bit and identifying some of those cases. It's nothing. We do a lot of work on tracking to make sure that we're not experiencing any kind of outbreaks or things like that. And we haven't had any alerts on outbreak trackers, but there is a slight increase this year versus some of the past couple of years due to the pandemic.
Okay, and on your first slide, there was a major spike. It looks like about 2014. What was that?
That was the Scott County HIV outbreak.
Okay.
And so that was definitely something that you can see on the data there, that came out of left field. And I was working at an HIV service organization at the time, and it was a big shock to us all. But, one of the things, the Scott County HIV outbreak has been a huge success story for Indiana because of the health outcomes that people have achieved. And so when we talk about the importance of reaching undetectable viral loads, Scott County has beaten the odds when they look at disease projections and the number of new cases that a community might experience because of their people having reached viral suppression. They have been far under what the CDC would have estimated new HIV cases to be because of their successful health outcomes.
Thanks, sir.
Yes, thank you.
Senator Poole.
Thank you, Madam Chair. On the Scott County outbreak, was that mostly due to intravenous needle use?
Absolutely. That was entirely related to injection substance use, yeah.
And the efforts that were taken in response to that, were did that include like needle sharing programs and things like that brought those numbers down, or?
Yeah, in Indiana, local communities make the determination of whether or not to start syringe service programs or harm reduction programs. The division does support both syringe and non-syringe harm reduction, depending on what localities determine is the best route for them. Scott County did start a syringe service program, and they had a very successful run of, engaging folks in services as part of that continuum of care. Beyond that, the medical care and the supportive services, mental health, substance use treatment, all of those things go into all of the work. We fund about 26 different kinds of services through Ryan White programming.
Thank you.
Yeah.
All right. Thank you very much. Could you do us a favor and send the PowerPoint to Annie so that we can have a copy of it?
Absolutely. Thank you.
All right. Thank you very much. Michael Moore with Public Defenders.
Thank you, Madam Chair, members of the committee. My name is Michael Moore, and I'm the Assistant Executive Director for the Indiana Public Defender Council. And on behalf of the council, we thank you for this opportunity to come and speak to you all about modernizing our criminal laws as they relate to people with HIV. I'm literally going to take 2 of my pages away because Dr. Foote did such a great job of covering the criminal context, the stigmatization that we see in Indiana, and all the really good reasons why we need to look at modernizing our laws. I'm going to just kind of focus on some potential recommendations and how to bring Indiana forward and modernize how we treat people who are living with HIV who are also criminally involved. One is, as you heard, the way the criminal law works in Indiana with respect to HIV is that we enhance already existing criminal laws. So the biting, the spitting, those are already crimes in Indiana, and we enhance those simply based on a person's status, regardless of their intent to transmit any disease. So we recommend removing those enhancements and treating criminal behavior as the underlying criminal behavior. Secondly, if there is a desire to continue with enhancements, we would recommend that there be a specific intent element added to the crime, sometimes called mens rea. So if I punch someone, spit on someone, I have the intent to commit that crime, but if I'm also HIV positive, it doesn't matter what my intent is. So we recommend adding the intent element to that portion of the enhancement if there's going to be continued enhancements provided in the criminal law. Third, a defense is something we don't see in Indiana. As you heard, there are a number of prophylactic measures people can take that render most people with HIV unable to even transmit the disease, and if they're HIV positive. So if a person is actively taking things like PrEP, using other prophylactics, including condoms and the like, that be a defense to the enhancement or to the crime if a person is charged with a crime that where HIV, if their status is HIV as an element, that they'd be able to raise the defense and the state can then disprove it beyond a reasonable doubt, as with any defense. And that would bring the crime in parity with other similar offenses. We'd like to see the penalties reduced from felonies. As you heard, it's a level 5. If I spit at an officer and I'm happen to be HIV positive, it's a level 5 versus a level 6 if I don't have HIV, and the only difference is simply the HIV status, even though for many people living with HIV, they can't transmit it because one, spit is not a good way to transmit HIV. It's impossible, as you've heard. And secondly, most people who are living with HIV who are taking those measures can't transmit the disease anyway. So if there's evidence the person is using prophylactics or medication or taking measures to protect themselves and others, that'd be a defense to the enhancement or to the underlying crime. And also reviewing any law that deals with criminalizing behavior where there's a medical element if the science doesn't support it any longer. So if the science is moving in a direction that says we can't transmit HIV through biting, spitting, other measures except for, generally speaking, unprotected sex or sharing of needles, then the law should reflect that as well. So I have a very short presentation that was much longer. I thought Dr. Foote did a great job of kind of reiterating the points that our laws do stigmatize people living with HIV. It makes it difficult for some people to come forward, get tested, know their status, get health treatment when needed, and continue to do so, and then engage with other partners and be open and honest about their situation, and also reminding people that because of the treatments we have available today, HIV cannot be transmitted by many people who have a viral load, as you heard the numbers are. So I can answer any questions regarding the criminal code. I'm not an expert unfortunately, in the HIV area, but we do have some ideas, I think, that would probably would modernize our laws and make them more equitable with other crimes that exist in Indiana.
All right. Looks like you don't have any questions. All right.
Thank you.
Just want to take a moment to recognize that Representative Clare is here today. Representative Clare's carried this language for the last couple of years. And with that, Representative John Young. Glad to have John here today.
Thank you, Madam Chairman. Thank you, members of the commission. My name is John Young. I'm a representative for District 47. I also practice criminal law as part of my practice. So, we looked at this bill last year, and I support it. I do believe that we do need to modernize some of this law, but there is a couple of things that I would like to talk about. One is I would urge that the bill specifically focus on intent and not the harm that results or the risk of harm. And I will give you a good example. Just think about all of our attempt laws. If I pull a gun out and I try and shoot somebody on the street, but I miss, the fact that I didn't shoot him and therefore didn't harm him does not make a difference in the fact that I intended to kill him or if I intended to rob that bank, okay? So what I don't like about the current law is this, I believe it says knowing disregard of the facts, okay? That should probably be dropped. However, to Senator Tom's point, if there is, say, a criminal defendant that is resisting arrest and telling a police officer, I have HIV and I'm going to give it to you if you don't get off me, and proceeds to bite him, proceeds to spit on him, throw bodily fluids at him, that should be an enhanced crime, in my opinion, because the individual has the intent to try and transmit the disease. If it is a circumstance where people are wrestling on the ground, as I believe Dr. Foote pointed out, or something like that, where there is no intent to do that, that is, I believe, where the law probably is lacking. Just as a final point, and I've spoken to doctors about this, and I have no disagreement with the medical information that was put out there, but one stat that I did see was that about 24% of individuals had an unmet HIV healthcare need. So that to me would mean that 1 in 4 individuals that I may meet on the street that have HIV, I should presume that they're not getting any treatment, that they are as positive as anybody. So if I were to say, leave the State House one night, go to my apartment, go out to dinner, and I was attacked, okay, I had, somebody come up to me, throw bodily fluids on me. Let's say I came across a traffic accident, okay, and helped an individual, maybe I got bled on, okay, or had something happen to me. And I've spoken again to doctors about this. If I went to that doctor and said, hey, this happened to me, all right, should I be tested? Should I have an HIV test done? All the doctors I spoke to said, yeah, I'd recommend it. Despite all the medical knowledge that says, yeah, you're likely not going to get it, okay? And it may be a hypothetical scenario. I just ask anybody on the commission, if that happened to you, would you trust the information you heard here, or would you still go get yourself tested? Thank you. Oh. And if there's any questions.
Any questions, Representative Young? Representative Bartlett?
So Representative Young, some of the testimony I heard here today was there's a stigma attached to the HIV. Is your question because of the stigma?
I would say that is what I dislike. That's why I don't like this knowledge, that you have this knowledge. It's nobody's business, and I don't think anybody should be forced to disclose, so let's say they talk to law enforcement. But I don't see a problem with somebody being stigmatized because they committed a crime. That's what I think about. I'll even think about, and I think our fraud laws covered this, but donating blood knowing you have HIV, all right, that is a current crime. But I would have a problem with somebody that is doing that to defraud a blood bank. They know that they're going in there, okay, to try and get money for something that they really shouldn't be giving. I wouldn't like the stigma of somebody going in there innocently, okay, and trying to give blood, maybe not knowing or thinking that, okay, I'm healthy enough to give blood now, even though they were wrong, and then being stigmatized by being reported versus somebody that's really wanting to commit a crime. That's where I'm trying to delineate this. I don't have sympathy for the criminals, but I have sympathy for, people that, simply would have HIV, and that's what I'm hoping the bill does, is strike some of that balance.
Ms. Corley?
Specific question about your intent idea.
Yeah.
So I'm looking at the donation language, and it is a level 5 to attempt to donate. But I mean, coming back that we know that the recipients of that blood, all the places where you donate, they go through protocols where they protect the blood, right? And so whether a person knows representative or they don't know or they intend or not, my question to you is, when you know that there are these protections on the receiving end, would you still want an intent on that specific charge?
On that, and we talked about this last year, and I spoke to IPAC, I would be, personally, if that provision was dropped on that to the blood banks altogether, I would be okay, because I think the current fraud statute, which I believe would be fraud under false pretenses, okay, would cover the situation. Now, the other thing I saw is, I'm not certain anybody was arrested or prosecuted for this, because I'm not even certain the blood banks report this if they find it out. I could be wrong, but the numbers may be shown today or that I saw. So, and I don't even know, I think the fraud statute at that point is probably a level 6. So on that end, so I was addressing Representative Bartlett's question more about the stigma, but specifically, I think, after talking with IPAC, that under the current fraud statute, even though it's a reduction in the level of offense, which I'm good with, I like criminal, defense laws going down, I think that would probably be reasonable. You're welcome.
Okay. Thank you, Representative.
All right. I hope I was brevity enough.
You were. Thank you very much. All right. A little bit of committee discussion. Does anybody have any comments, thoughts, ideas? Representative Pierce.
Just want to say generally I support the idea of updating these statutes, modernizing them somehow. Because I can remember, I think I was in college then, but I can remember when the whole AIDS pandemic kind of hit the news. It was pretty hysterical. We were all thinking that, the simplest interactions with people was going to somehow end up with us being dead in a couple years. And obviously over time, we've understood the disease better, and we have all these treatments. So I think that our statutes are definitely reflecting a different era than we're in today, and so it would make sense to update those.
I would agree.
All right, any other comments?
Yep.
Sarah Paul?
Thank you, Madam Chair. Yeah, I was really kind of blown away by the testimony from, and I cannot recall the first witness's name, but the transmission rates, kind of what the science shows is how these things are actually transmitted, or what the likelihood is, or the percentages. And I absolutely agree with Representative Pierce. I think a lot of these laws were probably written at a time where there was a lot more fear as to what the consequences were of some of these actions. I think that, given where we stand right now, I definitely think it's time to modernize. So thank you.
All right, any other comments? All right, thank you to the members for coming today.